Hi, everyone. My name is Dr. Jeffrey Jensen, Dean at the Arizona College of Podiatric Medicine and host of the Dean's Chat podcast. My guest today has had a storied career. Dr. Michael King is currently the Chief Medical Officer for Upperline Healthcare. Previously, he was the president of the American Podiatric Medical Association from 2011 to 2012, and prior to that, he had been on the board of trustees since 2000. Dr. King practiced in Massachusetts for 30 years and was president of the Massachusetts Foot and Ankle Society from 1995 to 1997. He is board certified by the American Board of Foot and Ankle Surgery. Dr. King is a frequent lecturer on coding, compliance, practice acquisitions, value-based healthcare, and evidence-based clinical measures. I don't think we're going to have a shortage of things to talk about, Dr. King.
No, I think we have plenty, Jeff.
Absolutely. Dr. King was also recently honored as a fellow in the Royal College of Physicians and Surgeons in Glasgow. Welcome to Dean's Chat, Dr. King.
Thanks, Jeff. Dr. Jensen, very good to see you as always. Pleasure. Thank you for having me.
Oh, thanks for jumping on. It's middle of the week. Hump day, so we'll get on with it. You know, we have a fireside chat vibe here, Mike, so we go with first names. If that's okay with you, we'll go with Mike and Jeff.
Oh, wait, well, you and I have been down that way for a while, so I think we'll be fine. Yes, absolutely.
Absolutely.
I've been Mike a lot longer than doctor, so I'm okay with that.
You know what? I feel the same way. And after being in practice in the hospital those years, we don't really need to be called doctor anymore.
No, I knew who I am. Yeah.
Yep, absolutely. Well, you know, Mike, I thought what we would do is dive right into your current role as the Chief Medical Officer at Upperline Health. You've been the Chief Medical Officer since 2018 now, and I think the landscape for practice acquisition and accountable care organizations, all of that is so fascinating, and I'm sure our listeners would appreciate kind of getting some background on what Upperline's all about and how you got involved as the Chief Medical Officer.
No, that's great. I could probably do the whole segment on this little piece, but it's interesting. During my APMA days, I got a lot of interest in health policy, the development of the compliance side of it, the coding side of it, of course, but even the development of models of practice. Needless to say, Jeff, is that there aren't a lot of positions that look for DPMs to be in leadership roles. You look at hospitals, you look at insurance companies, you look at whatever. That's their problem, but we'll fix that one day. But it happened that Upperline came along in late 2017, and the cute story was that a headhunter actually reached out through a friend, a vendor, believe it or not, and said, maybe this guy will want to talk to you. And so I said, yeah. And he reached out to me, David Thorpe, our CEO, and David said, are you ever in Nashville? I said, well, it's pretty funny. I'm actually here now. I'm a consultant for PICA, our malpractice company. So I was in Franklin, which is 10 miles south. And he said, yeah, if you got 20 minutes, we'll just talk for a little bit. Said, yeah, it'd be perfect. So he said, he came down 3.5 hours later. Wow. We got done talking because he was one of the few people, Jeff, I've ever met that had a vision for our profession that you and I and other people who in education and leadership realize where we're at, that we actually have a primary care role in medicine. As we get in the ACO chat, we'll talk more about this, but we see more sick and sicker people than any other specialty on a regular basis. People will see their PCP once a year, if that. They'll see their endocrinologist twice a year, if that. They'll see us 4 times, whether it rains, snows, blizzards, sleets, and they have a broken leg. Absolutely. And the data shows that. So anyway, Upperline was developed. When I came on, we had 4 providers and 4 clinics, and now we have 160 and about 60 more nurse practitioners, vascular specialists. And, the growth's been incredible, and that's a testament to our CEO and to our whole team. To your acquisition question, originally we began by the acquisition, and I'm no fool. They didn't hire me for my clinical knowledge. They hired me for my Rolodex, which is okay, because I could call a Jeff Jensen, I could call Jeff Robbins, I could call a Patrick DeHeer, a Jeff DeSantis, and Ira Kraus. I mean, I could, name drop all day. But, so we started to look for the best and the brightest, from the Dr. DeHeer, DeSantis, Case, Pascarella in Florida, Rust in Florida, Banks and Ruck through the Village Podiatry Group, And that's how we built. So we wanted to have a good base, stable base of really strong, well recognized, successful practitioners that we then could build around. And that's kind of how Upperline has developed.
Oh, so you say you have 160 providers now. How many states are you in, Mike?
We are in 7 and maybe in 9 soon, but right now we are in 7. So we're in Florida, Georgia, Alabama, Tennessee, Kentucky, Indiana, and California presently.
Very good. So if I were to ask you, what is the mission of Upperline Health, what would you say?
The mission is to transform podiatric medicine into one primary care, but through value-based healthcare. And so, all of us know that the system is relatively broken, and needs to be fixed. The expenses are ridiculous, and the cost of things, people going bankrupt for care. And so our mission really is to transform specialty care of the lower extremity and beyond, but beginning as the podiatric physician as the lead provider in the recognition of those conditions, and then making sure they're funneled to people who can manage them. So I'm not saying as a primary care doctor, we'll manage that essential hypertension. Maybe someday that'll happen, but we will recognize the presence of that, which I know you did in practice and I did in practice. And I can tell you that our doctors do. Most large groups take 5 to 7 years, Jeff, to capture the amount of codes that we have captured in 8 months.
Wow.
And that's not a testament to me. That's a testament to our colleagues.
Sure.
Because we see the disease and we recognize it and we make sure it's managed instead of having them wait a year for a visit.
And that makes perfect sense. So I when I'm thinking about a super group, right? I don't know if that's a good term to use or not, Mike, but I think of...
Well, my boss hates the term, but I guess in essence we are.
Okay, then we won't use it. But when you're putting together a group of phenomenal doctors, and there's got to be an element of economies of scale also.
Yes.
Working together. So how does that work? What is Upperline helping provide those practices to enable an economies of scale?
So, as you can imagine, I'm sure you've discussed burnout, administrative burdens, and so one of the biggest reasons, people, yes, they get money for their practice. Some people are looking for an exit strategy, but the greater part of it is administrative relief. And so we, as a team at Upperline, actually have management teams that manage the clinics. So what the doctors can do is go do what they do, do what they do best, see patients, manage patients, make a gainful living, and then go home. I mean, but it's hard work, and it doesn't mean that the work isn't easy, but that management side of it is now in the hands of business people who like doing that and have the energy and the time and the teamwork to do that. So, to your points of scale is that we're all on Athena. That's our EMR. So everybody's on that. I wrote the first 150 macros, podiatric macros for Athena. And then everybody builds versions of theirs with what are called saved findings. So we're all in the same EMR. We've slowly transitioned to all the same tax ID system. We have a portal and a formulary for ordering supplies, cellular tissue products, and we're slowly refining all those other things, because you can imagine, Jeff, to your point, when you take all those different clinics, there's one vendor here and one vendor here and one vendor here and one vendor here, and we're working on slowly getting a little bit of consolidation of that. So the economy of scale is, hopefully it makes it easier for the doctor to just do what they like to do. Just see patients, make them better, go home, be happy.
Absolutely. I always thought the perfect world would be see your patients, do your surgeries, do your notes, interface with the referring docs, and come back the next day and do it again. So
yes, and ideally that's what we want to see happen. And is it perfect? It's certainly not. We're growing and we're learning as we grow, and the doctors give us help and give us advice. And it's a merger of the business minds and the clinical minds and the business clinical minds, and making that all work. And so far it's been really good.
What is it about your CEO, David Thorpe? I met him in Nashville when we went to that Storytellers event. That was so much fun. Seemed like a very engaging, energetic, very professional, I want to say young man, but he's younger than we are. But what did you see in him? When you met for 3 hours, what did you see in David?
Well, the intelligence is somewhat obvious when you start to talk about topics. It was the enthusiasm for my profession, our profession. And Jeff, we don't always get that.
Right.
We get it internally. And sometimes you get it externally, but we don't get that as much as we would like. I was at AMA meetings and AOA meetings, and I was treated with respect and treated well, but there was never this enthusiasm for what we do. Mr. Thorpe has the enthusiasm for what we do, and it was rapidly displayed. And as you saw too, yes, he's very vocal. He's loud. We can always tell when David's in the building when he laughs because it echoes through the whole place. He likes to laugh, but he's a brilliant healthcare guy. He doesn't take any crap. He speaks his piece. He's vocal, but he listens. And so, that's what resonated with me. It was the first time I had met someone in a long time with the enthusiasm to do something for our profession that I hadn't seen in a long time, external to us. So that was the biggest thing. And David got his chops in Tennessee Medicaid, and then he was part of a hospice company called Aspire. End of life. And an interesting point, Jeff, I think you'll appreciate this in the development of, is one of the problems they saw at the end of life were wound care problems. Extremely expensive, extremely devastating for these patients at the end of life. And how, David saw that with discussions with payers and the systems, how do we change that paradigm? And it's like, well, that's easy. It's the podiatrist. I about fell off my chair the first time he said that because I knew that, you know that, and our colleagues here know that. David knew that. And he said, I'm willing to risk my career building this entity around that knowledge, is that they have the ability to change the paradigm of healthcare.
That's brilliant. So when you got on board in 2018, what did David task you with as the chief medical officer? What was your onboarding like the first 6 months? And then how has it evolved over the last 5 years or so?
Well, it's interesting. I walked in the building, Jeff, and we had a little corporate office, and it wasn't massive, but it was decent. And there were 4 of us. There was David Thorpe and Stephen Nash, who was a co-founder, who was a chief strategy officer, one of David's friends from Aspire, and a young fellow, John Morphus, who was doing M&A cold calls. And of course, people were all hanging up on him because nobody knew who he was. So he tasked me with starting to build a list. If you built your own super group, who would you want to call?
Right.
Who would you like to start with? Who do you think would have an interest? Who could build? Who's a surgeon? Who's a wound guy? Who's a nail guy? Who's a mechanic, whatever the right term is? How would you build that? So that was one task. Secondly was to teach him podiatry. So it's interesting. We would spend hours every day whiteboarding, and he would teach me business. Here's a PC, here's an Inc., here's a PC, here's an LLC, here's the corporate practice of medicine, here's the structure of hierarchy of how business people look at it. And I would go, here's heel pain, and here's the 99 reasons you can have heel pain, and here's how you manage each of them. And then from there, I was tasked with building protocols, which I had done with help with Dr. Ira Kraus when we were at EHI, or Village Podiatry. So I was tasked with building protocols, and then roughly a year later was the Athena work, and that took me 9 months. So the biggest thing was finding docs to start our growth, making those phone calls, making the connections, using my Rolodex, and then working also on the clinical side of, what do we expect our doctors or want our doctors to do so that they're good, so their outcomes are good. And, the cost-effective part of it comes in more and more into play now with the ACO. But at the same time, making sure that, they were making a good living, but at the same time, they were doing what they needed to do to get patients better. So that we would get good NPS scores from our patients, so that the net promoter scores, and now it's a big deal. If the patients are happy, that's going to resonate not only in your own personal practice, but across the profession.
Right. No, that makes sense. And it also makes sense that if you go out and you hire the best, it rises everybody up.
Absolutely. We have so many phenomenal doctors. We really do. Dr. DeHeer, and again, Pascarella, Rust, Banks, Ruck, DeSantis, all of them. And it's, they've all, like you said, what is it? The tide floats all boats, or high tide flight, I think. And that's part of what we want to do. And is we add more and more young physicians now, because we haven't been doing as much in the acquisition side as we are doing in the de novo side. So we're opening clinics. I think we hired 30 residents last year and another 20 or so this year.
Wow.
So you give them a job, and some love it, some don't, but that's part of what the life is. But the point is, we can hopefully let them learn early this system and actually grow in this system. And we have some that are just exploding, which is wonderful to see.
Oh, that is wonderful. Yeah, that's kind of a nice segue because you beat me to the punch, Mike. I was going to ask you, so if I'm a third-year resident right now, right? It's November. I'm going to graduate in about 8 months, and I'm looking for employment opportunities. I had heard through the grapevine that Upperline was the number one hiring entity within our profession for residents coming out. How does that work? Like, do they contact you, or are you putting out ads, or are they looking for location?
Yeah. Combination of those, Jeff. Some people will hear from, they might talk to Dr. Jensen and he says, hey, give Mike a call. Some people do that. Somebody might know Dr. DeSantis in California and say, hey, I went to Western, or Dr. Labovitz told me, or hey, Jeff DeSantis told me there might be a job in San Diego. Or we have a whole recruiting team that actually puts ads in Indeed and LinkedIn. So a lot of places come through those sites as well. So it's kind of a combination of factors. Some people know me that way, some don't, especially the younger generation. I'm in the has-been club, so it's okay.
It is okay.
We're rite of passage.
We're there together. It's good.
Well, there you go. It's the rite of passage. But yeah, we have several different mechanisms. So we have a recruiting team that specifically works on the physician side of things, and then we have a recruiting team that works on the corporate side of things, and then they tend to commingle.
So if I were to send you,
by the way, word of mouth too from colleagues. So like somebody might have been hired, or a friend, and say, hey, why don't you give them a call? I've been happy. Or hey, I have to move because my husband's job's changing, whatever. And why don't you give them a call? So things like that. That's another one. Yeah.
Oh, that's fabulous. So in addition to growing this mega practice, instead of super group, you were looking at this accountable care organization, ACO. And that's new to podiatric medicine. Upperline is the first podiatric entity to become a provider within an ACO to the extent that you are. Can you give us a little background on that and not only where we're at today, but where we're heading in the future?
Absolutely. So I'll try not to be too soapboxy here. Medicare and CMS has made it very clear that they want all of Medicare to be value-based medicine by 2030. Okay. Whether they pull that off or not is debatable, but that is what they are saying. So that means we need to be part of that. If you look at Medicare Advantage plans, those are the model, if you will, to go there. They are not without their issues, needless to say, but they're in that same realm where they're given a set sum of money based upon the disease states of the patients they care for. Value-based healthcare is around that. It's basically finding disease early, managing the disease, as opposed to simply saying, yeah, Dr. Jensen, you have hypertension, see you in a year. You have Dr. Jensen, you have hypertension, let's manage it. Let's not have you spend 5 times in the emergency department or 3 admissions this year. Let's manage you. Oh, by the way, I'll see you at home. I'll telehealth you. I'll manage you. Let's get you off those 3 other meds and get you on one that works, et cetera. So that's kind of value-based at the essence of making sure that each condition's managed. But you're correct, is that there has never been a podiatric ACO. Number one, we're the first. Medicare has talked about specialty care in ACOs for a while, but apparently they've grappled with how to do it. So to the benefit of us, the person who invented the ACO REACH program, which is this new iteration, because it started with the pioneer models back around 2012, some flew, some didn't, and then there's 2 or 3 iterations in the middle. Now we're at ACO REACH, which is realizing equity and access to care and health systems, or something like that, REACH. The person who invented that was on CMMI, which is the Innovations Department for Medicare, and his name was Adam Bowler. Adam now is in private equity in his own thing, but Adam is a friend of Mr. Thorpe's and a member of our board. So this is the direction that 6 years ago, David and I talked about we wanted to go. This is the fruition of that. Now, is it completed? Certainly not by far, but this is the fruition of that dream of having a value-based system. And so what that means is that it's getting your Medicare population, those that desire or are not already part of another one, most of them don't even know if they are, into this accountable care. benefits for them, access to dietitian, pharmacy, nurse practitioner, podiatrist all the time, MD when needed, social work, psychological counseling at no cost. So these patients do we're using what's called voluntary alignment. So the patients are given the option with the checklist. Some join, some don't, which you can imagine, which is fine. Some don't trust. Sure. This is the no free lunch generation, so they're not so sure about what they should trust. But we have teams that help to sign people up who had an interest. No strong arming. We've signed up somewhere between close to 40,000 people. Medicare aligns or approves these patients every quarter. And so you might have 22,000 signed up now and 30,000 the next quarter and 35, it depends. But as I mentioned earlier, Jeff, the thing that can make this work and is working so far is that we see these patients 4, 5, 6 times a year all the time. And if my numbers are right, 70% of our Medicare patients have not seen their PCP in a year.
I believe that.
But God forbid they don't see us.
Right.
So that's kind of where it came about. This is the fruition. This is in fact a value-based health model, population health model that focuses around finding disease early, recognizing, managing. By the way, a question a lot of people ask about is, well, I'm going to really make mad all of my referring doctors. 90% of them have been thrilled we're doing this because they don't have the time, the energy, or the resources to manage a person day to day to day. And so the first thing if our podiatrist recognizes your problem and our nurse practitioner sees you, and we have healthcare coordinators who help coordinate all of those services, the first thing they do is reach out to the PCP or the endocrinologist, the internist, and say, hey, Dr. Jensen's here today, and I have this issue, and he's really concerned about, I'm concerned about, et cetera. Well, this is what I like to do. And 9 out of 10 have said, knock yourself out. Please do it. And there's always some people who are territorial, and that's fine. We all would be. But anyway, that's kind of what it's all about. And ultimately, if what I would see a goal as a 40-year podiatrist is that we are recognized as primary care. And maybe, this battle we've had over the Medicaid designation at Medicare for the last 20 years, we're physician under Medicare, as you know, but we're not under Medicaid. It's state to state. Will it just change that? Because all of a sudden we're primary care, little pie in the sky maybe, but those are the sort of things that I'm thinking about that, and, give us our rightful place where we belong in the health system.
Absolutely. Mike, I'm having flashbacks to when I was in practice and all the times I was doing clinical trials or seeing my patients and making the phone call to the primary care. I remember one time I'd call and say, hey, I've got a patient, their A1C is 16, and they'll pull you a chart and they'll say, well, I haven't seen that patient in 3 years. And they keep canceling their appointments. So, we could have seen this coming a long time ago.
Jeff, we had a woman, real quick, I'll try to do this, saw a physician, one of our doctors in Kentucky, at-risk foot care, nail care. I know it's boring sounding, it's boring appearing, it's not sexy, but that visit found a woman who said, through discussions, I've been in the emergency room 5 times in 2 months. I've been hospitalized 3 times. Her blood sugar was taken. It was 32. She'd had a gastric band, placed on Ozempic, and had 2 different versions of hypertension medicine and her usual dose of insulin. No one saw her. Our nurse practitioner called our CMO of the ACO side right away and said, whoa, this woman could die. But the point is that instead of her going back to the emergency room, by the way, we called the endocrinologist January. This is from September. With PCP, January. Our nurse practitioner managed the problem within 3 days.
There you go.
And so, the testament is that the system gets rewarded for that because you've saved a lot of money. And the part that I always wrestled with, Jeff, is will the insurers really give us more money if we save them money? Well, on the Medicare side of the world, they will. Okay. Will that trickle down through the other systems? I think we'll see over time, because the one thing I've really noticed is that everyone has a very hard time getting their mind out of the fee-for-service world and into that capitated or bundled payment world.
Right. No, that makes sense, because I can see going into an area and cleaning up all the diabetic foot concerns, all the peripheral vascular concerns, all the things related to the lower extremity. And then once you've got everything under control, are they going to keep paying you for that, right?
Well, right. I mean, the one thing is that, as you've noticed, I'm sure in practice, is that there's a ready supply. I mean, we're looking at 30 million diabetics in this country now, looking at maybe 40 to 50 by 2030, 33, with 10 million of those having peripheral neuropathy. I mean, it's, massive numbers.
Absolutely. Mike, just a side story. When I was in practice, we would work with the insurance companies and with physician groups that were going at risk. And we were doing case rates for diabetic feet and with inclusion-exclusion criteria. And we would get one fee for the year. So that's when the rubber hits the road, right? That's when you start healing patients in a hurry. So I thought that made a big difference. You are,
it's indeed a challenge because you still have to be, it's a budget neutral world basically, and you have to manage those patients. But if you do it effectively, are you going to be snake bit sometimes? Yes, you are. I mean, you can't control life, death, or cancer, but you can control what you can control.
Absolutely. Well said. Well said. Mike, you're absolutely right. We could keep going on this for another hour, but I wanted to shift gears a little bit, and I wanted to talk about your contributions to the profession. I know that you were in practice for 30 years in Massachusetts, and you were involved locally, right, with the Massachusetts Foot and Ankle Society. But I wanted to talk about your contributions with the APMA. It culminated in your presidency between 2011 and 2012. But would you mind sharing with our audience and listeners how you got involved with APMA and how that 10 years being on the board of trustees led up to you being the president?
Yeah, thank you. That's great. And I appreciate nice comments. Well, when I started in Massachusetts, interestingly enough, it was the old guard of time, and I went to a couple of board meetings, and I was not very welcomed. Which is, typical. Here's the young guy who wants to do whatever. And then I became welcomed after being a frequent pain in the butt by sitting there and I kept my mouth shut. I learned early. I know you've talked about this with a lot of people. I was lucky to have a mentor like Jack George and Lloyd Smith, who were hard on me, but they taught me. And when I say hard on me, I don't mean cruel or anything, just that, they expected certain things of me. But I enjoyed that. I mean, I was the OPMSA president at Kent State when I was in school and my fraternity, and I just have always enjoyed that kind of stuff. So then I was lucky. I moved up through the chairs there. I was the president actually from 95 to 96, but I was negotiating with Blue Shield. Blue Shield only paid 3 codes for podiatry in 1995, not including E&M visits. And so I was lucky enough to have a medical director there, a rheumatologist who was very open-minded, and we talked for 2 years. So I got an extension of a year from the membership so I could finish that. And so when we got done, we had the book. We got it open.
Right.
And that was, thank God for, an open-minded person at Blue Shield. So that's, I was very excited then. Dr. Smith was already on the board. He was president, around that maybe 2006, 7, and don't remember, but he was already on the board. And so I was anxious to do that. And so I ran in 2000. I was lucky enough to get elected. I sat in the House of Delegates for 3 or 4 years before that, by the way. Another cute story was I got a call, I think it was in 96, from Dr. Terry Albright, who was president at the time. And he said, hey, you're going to be the chair of coding. And I said, what? I said, I don't know anything about that except what I'm doing. He says, well, you got 6 weeks to learn. Don't worry about it. There's only a couple people on the committee, Paul Kinberg, Harry Goldsmith. I'm like, the people I read all the time.
Right.
Anyway, that's how I got my coding chops. And then as I got on the board in 2000, Doug Sowell, the late Doug Sowell, was the president. Okay. And he was the first podiatrist ever on the AMA CPT editorial panel. And so Doug took me under his wing and taught me the politics of coding. Wow. And so I sat at the panel as an advisor for, 7 or 8 years. And then Phil Ward took over, and now Ira Kraus is there. And then during that time, in my time on the board, I was on health policy, health systems, coding, a couple of the other committees that we all kind of run around because they try to get a good vision of everything that's going on. And I was fortunate enough. I mean, when I was president in 2011, I was lucky. It was a really good year for APMA. We had good membership, we had good money, we had good leadership. Worked with Dr. Gastworth, who was the executive director at the time. We had a great relationship. We started the first podiatric membership category in the SVS, Society for Vascular Surgeons. So I was member 001.
I love that.
So that was pretty exciting. My most exciting thing I think I did that most people don't even realize or think they're using is called the Center for Professional Advocacy, which is the APMA branch for hospital issues, credentialing issues, maybe even some compliance. But that was my baby with Dr. Leverio. And we got that through the House of Delegates, I think, in maybe 2009, 2010. And it still exists today. So that's one of my prouder things that most people don't even know about. But for me, that was something I wanted to achieve. But it was great. I loved it, Jeff. I mean, I got to know people like you. I mean, there's many people I would never have met, and it got me my job today. I mean, that's true too. But I loved the politics. I loved the medical politics. I loved all the people around the country. Our colleagues are just wonderful. There's a few curmudgeons here and there, but when I go to Philadelphia, I saw 10 of them that I hadn't seen in years. And I went to New York the other day to lecture, and I saw some more. And that was the best part for me, was a feeling like maybe I gave something back, because it gave me a great career. Went off to home, putting 2 kids through college, and that's the part. And I know recruitment's near and dear to your heart. That's the part that still just befuddles me, is that this is such an amazing career, and it isn't easy. But what is? But at the same time, it's incredibly rewarding.
Anything worthwhile is going to take a lot of work and a lot of effort and a lot of passion, right?
Yes. And that, and that was, I guess you could just say that's a passion of mine. The coding and committee, and I love that stuff, but the interaction and the politicking, it was fun.
What was the year like when you were president? You got inaugurated in March. What was that year like? It must have been a whirlwind.
It was a whirlwind. I was on the road about 200 days.
Really?
So it was a little hard on the practice. I had a wonderful couple associates, so thank God for that. My staff was great. My family was wonderful. But it was awesome. I went to, 15, 20 different states and meetings. I got to go to the AMA meeting, AOA meeting, SVS meeting. One of the highlights is I got to speak. The AMA president and I addressed the labor union meeting in Miami, the AFL-CIO.
Oh, fantastic.
So things like that. I had dinner with the Surgeon General. So just things like that. The AOA they opened their advocacy center in Washington, and they invited me to come to the opening. So it was a whirlwind, but it was an awesome year. Again, it was the relationships. Jeff, it's all about relationships. And I met you through that side of the world, so, but yeah, it was a whirlwind, but it had its times. I think we had a really good year. I was very blessed. We had a good year for the profession. We had a good year for the membership. We had a good year for the association. We were still in the throes of the separation between ACFAS and APMA. So there was a little bit of pain with that, being a member of both.
Sure.
But otherwise, it was wonderful, and it's an honor I truly cherish.
Oh, that's incredible. Yeah, on behalf of the profession, Mike, you've given so much back. Just awesome, and thank you.
Well, thank you. That's very nice. It's been a labor of love, just like what you're doing.
Sure. Well, so you mentioned your family and your kids.
Yes.
And this past summer, I was following you on social media, and you had the opportunity to go to Scotland and become a fellow in the Royal College of Physicians and Surgeons in Glasgow, and it looked like it was a whole family affair. What was that like for you?
That was very, very cool. So yes, number one, my son-in-law's entire family is from Northern Ireland.
Oh, wow.
So Kevin grew up here, but his parents came here when they were young adults or late teens. So Kevin was raised here, but he has many, 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 many aunts and uncles in Northern Ireland and around the UK. So anyway, we decided to make it a family affair. It was my 40th anniversary for wedding this year, 40th year out of podiatry school. That whole thing came. So let's all go. So my son and his girlfriend went, my daughter and her husband, and my new granddaughter, who's 14 months now, and my wife. And so we just had a ball. We did Edinburgh, Glasgow. The way they treat us as an entity in the Royal College is just wonderful. Sorry, my watch talking to me. I got to golf at Royal Troon. So for any of you that are any of you that are golfers, it's where the British Open is next year. So here's another connection. Stuart Baird, who was the dean at the College of Glasgow, frequently came to APMA to give a talk about the UK. And so when I was going, I sent Stuart a note that I was coming, and he insisted that my son and I golf at Royal Troon. So we actually got a bucket list golf day in at Royal Troon. Then we did the ceremony, which was just beautiful in this Harry Potter type castle, and they treated us just wonderfully. And then we went to Ireland from there. And unfortunately, we all got COVID at the end of the trip. But nobody got really sick. But anyway, Jeff, it was a very nice honor. I was nominated by Lee Rogers and Jeff DeSantis. So, thank you to them for helping me get there. But it was very special. And it's interesting because, I use this term a lot, and it's kind of trite, but we're sort of the redheaded stepchildren in medicine here, even though we're trying to change all of that. But over there, you're a big deal,
right?
Because I was sitting next to the president of the Israeli Society, and on the other side was the president of the Irish Society, and they're both asking me, "Well, you do surgery? You really do? You do that?" It's like, well, yeah. What do you do? So I went through some of this stuff. Now, their eyes were just popping out. To them, we're the gold standard for podiatric medicine, which is exciting because it says to me, we're doing something right. So
absolutely.
But it was great, a very nice honor, and beautiful people, wonderful people.
Well, that's fabulous. Lee, our family got to experience that a few years back, and Lee nominated me also, and it was just one of our best family get-togethers that we've ever had. So it was
great,
living vicariously through you this summer.
I was walking into the line, and my grandson or my son-in-law was holding up my granddaughter so she could see me. Not like she really noticed, she's a year old, but it made my day just to see her up in the air like that. It was really cool.
Oh, that's fantastic. Wow. Great memories for your family. That's great. So,
yes,
Mike, what do you do? I mean, I imagine you're completely consumed with podiatric medicine, but what do you do for fun? What do you do to recharge the battery? I know your family's wonderful, but what else do you do? What would our audience not know about you?
Well, I'm a very passionate cyclist. I try to do 50 to 100 miles a week. I haven't been as good lately for different reasons, but I'm a passionate cyclist. So I do easily 2,500 to 3,000 miles a year. I may not look like it, but I am a passionate cyclist. I love road cycling. I picked it up 10 or 12 years ago, as my hips started to wear out and my body got older and et cetera. I got on a bike, and then I upgraded a little bit, and then upgraded another one. And then last year I bought myself a little Ferrari kind of a bike. And I've done several 75 mile an hour rides. But being in Rhode Island, I can ride by the ocean for many miles. So that's my biggest athletic or pastime passion. I do like to read. I don't read as much as I used to. I do a lot of audiobooks though, because of, not unlike you, I'm spending much time reading papers or looking at computers. So I do audiobooks. And then the rest is really family. I mean, I tinker around the house a little bit. I can't say that I'm handy. I'm functional. My wife would definitely not say I'm not handy. But I'm functional around the house. My father could walk in a room, Jeff, and go, okay, you need that, and build the room. My brother's the same way. I would go in and say, nope, I can't do that. But so, yeah, mostly it's hanging around, it's tinker time, being with my family. And then, but for my own personal sake, when I get on my bike, I can go for 3 or 4 hours and just disappear. It's wonderful.
That's fantastic. What a great sport. So, Mike, I'm just going to shift gears again a little bit. If I'm a prospective student and I'm considering podiatric medicine and I came to you for some advice, what would you say?
I would say, look, you should take a look at every specialty that's out there, because that's what I did. And quite frankly, I wanted to be an oncologist. And my mentor in medicine, whose name was Donald Leffler, God rest his soul, been gone a while, was the most amazing, compassionate physician I've ever known. And he took me everywhere, Jeff, to watch patients die, to tell them they're going to die, to tell them they're going to live, to whatever. But I saw it taking its toll on him. That convinced me I shouldn't do it because I'm a little too mushy. Fine. So I started to look around and I said, where can I be? What do I really want to do? So I started looking at the dentistry, not too icky. I don't like mouths. Maybe other specialties. I don't know. Orthopedics appealed to me a little bit. And then I actually found podiatry, believe it or not, in health fair. And what appealed to me was I'm a dermatologist, I'm a surgeon, I'm an orthotist, I'm a psychiatrist, I'm a psychologist, I'm a caregiver, I'm a compassionate provider, I'm a hospitalist. And I go home at night and generally stay there. So I thought that was pretty appealing to me. So I dug into it a little deeper, ended up, I applied to 2 or 3 schools, got into Ohio, and I grew up near Ohio, and I went to undergrad about 10 miles from Kent. So it was perfect. And my parents were still there. Anyway, so that's a whole side point. The point was that it gave me the opportunity to say, this is really neat. And I heard some of the bad things about it because there's always the bad people. And we didn't have social media and all that crap that's out there now like they do. And I heard, for example, Dr. Leffler said, well, are you going to be a real doctor or are you going to do that? Mm. And I said, I'm going to be a real doctor. I said, but it's up to me to become that real doctor. Okay. And he respected that. So my goal when I was in school was to be a real doctor. And that's how I see it. So my point is when you're looking at it is that it's an amazing career with so much diversity of things you can see and do. Maybe you're not saving a life on the spot like a cardiovascular surgeon, but quite frankly, they see patients one time and never see them again. Are you changing lives? You're changing lives. You may not realize it. And sometimes it's not as obvious. But if you can't walk, if you can't sleep, and everybody who walks in your door says, oh my God, when your feet hurt, everything hurts. And it's like, how many times do you hear that, Jeff? And you go, okay, yeah, I know, yeah. But it's a rewarding profession where you can have a great career. It's a lot of work. Nothing in medicine is easy. But if it was easy, everybody in the world would do it, right?
I tell my students that every day.
There you go. But it's not hard either. I did manual labor. I drove a dump truck in college, and I loved that. But, I know, and I worked at General Motors for a summer. That double convinced me I wanted to go to med school. No reflection on those people. It's just it wasn't for me. I needed something to use my mind, my hands, and get a result besides just pulling scrap metal into a furnace. And again, I'm not degrading. My father was a laborer. But the career, Jeff, I think that's what befuddles me. And I know you and I have talked about this a little bit before, is that when you see the negativity that some people put out, it's where are most of the things you read in the social media, the negative stuff? It's because they have nowhere else to vent and all they want to do is vent. But just like I would say to my staff in my office, and I say to my young doctors, if you make somebody really miserable, a patient, they're going to tell 7 people. If you make somebody really happy, they're going to tell 1 or 2. Because the nature is to lean to the negative. So my only comment would be around all that stuff that's been out there about the negativity of podiatry, that's bull hockey.
I'm with you.
That's bull crap. And is it have its challenges and it have its downsides? Sure it does. But you know what? Where it is today, Jeff, I don't want to sound like Abe Lincoln, but compared to where we came from, Blue Shield paid for 3 codes. They only got injections in Massachusetts 3 or 4 years before I started there. So not that I changed the world or you, or the point is the world has changed. We are now mainstream specialists. Why are there so many orthopedic surgery groups hiring podiatric trained physicians? Because they know we're the best in the world at foot and ankle care, from surgery to nails.
Well said.
We are the best at finding systemic disease faster than anybody because that's how we're trained. We don't have to manage all those things. So I guess, again, I'm certainly soapboxing now, Jeff, but, it's a great career. It's not without its challenges, and there will always be challenges. I'll tell you what, come in the business side of my company. You want to see challenges? They got their hands full too, and they're up nights and they're worried and they're doing whatever's. many times more often than I was in practice.
Absolutely. Oh, that's well said.
It's a great career. I mean, just take a look with open eyes. Don't listen to people on the outside. Listen to your heart and your head. It's going to tell you what you should do. And I would be shocked if you're disappointed.
I totally agree with you. And, get out and shadow, go and see multiple different specialties and really get an idea of what podiatric medicine is all about. Mike, interesting story. A lot of our students coming in are past medical assistants in podiatric practices or transcriptionists, and
Yes.
they understand what our profession's about, and it's wonderful. So, well said.
Dr. Sanchez has had many MAs and scribes go to podiatry school. Matter of fact, one works for us in his clinic now.
Oh, that's great.
And you're right. And I know Dr. Krause has had a couple of those too. And and I think to your point, Jeff, is that to our colleagues, mentor somebody. If someone wants to come and see you, you don't have to sit there and spend every single minute, explaining every single thing, but let them see what you do. Just be yourself, do your practice, do your thing, and let them make their judgments. If they're really open-minded and they see the enjoyment that you get, I hope you do, and your patients do. Because patients are going to walk in the door and, oh my God, I love Dr. Jensen. He's so nice to me. That's the kind of stuff that makes you want to go back the next day. It's like golf. You hit a couple of good shots. You're ready to play the next round, even though you shot a 97.
There you go. There you go. Well, Mike, I concur 100%. And those are words of wisdom out there. So thank you so much. So Mike, we're running a little short on time. I wanted to thank you for making time to join me on Dean's Chat and talk about Upperline and talk about your experiences in this wonderful career with APMA presidency. On behalf of the whole profession, thank you for all you do.
Thank you. And thank you, Jeff, for doing this. I mean, for the profession. It's good to see, someone talking to people and their different experiences and hope you want to look at social media, young guys, go out there and watch the stuff like this. You're going to hear the real story from people. Some of us, some who love and some who have whatever. But the point is, be open-minded and you will not regret it.
Nope. Well said.
Everything in my life, basically, that I have to owe today, I owe to being a podiatrist. And that's a quote from Dr. Ross Taubman, by the way, so I have to give him credit for that.
Yeah,
I thought about after what Ross said, he was right. I met my wife in podiatry school. I got my career from podiatry school. I put 2 years through college from podiatry. And now I'm on the board at Kent, and I'm happy to be there because they gave me a wonderful life. And I just want to say thank you to them. And that's it. But thank you, Jeff. It's nice. Thank you for having me. It's been fun.
It's a pleasure, and we can do it again down the road. Say, Mike, I'm going to send you one of these Dean's Chat cups so you can drink some coffee.
Awesome.
You can get caffeinated before one of your long bike rides. And then I might need 2.
I need 2 hits.
All right, we'll see.
One cup's fine. I'll have 2 hits. Yeah.
There you go. And I want to talk to all of our listeners and all of our viewers. And if you are on Spotify or Apple Podcasts, please give us a 5-star rating. And if you're on YouTube, by all means, become a subscriber. And until next week, cheers, everyone.